Okay. Right. Can you guys see? Yeah, so we're quite lucky we've got this nice big screen, so it should be easy to follow along with what we're seeing. So for those of you who are starting with us, so Mondays, ECGs, Wednesdays, X-rays, and Fridays, just general topics. Although at the moment we're busy with toxicology. All right? So if you've been following the ECGs, good. If you haven't, you can always go back. Are you guys in the group? No. There's a whole group of you. Okay. So are you on the group? All right. I've got your number somewhere, and I'll add you. I'll send you the link because now it's only on Telegram that we've got space. The WhatsApp group is kind of sure. Okay. So, but in any case, now you guys are second years. You should have an idea of what's going on a bit with ECGs, but just in case. So today we're having a look at quite an interesting one. Okay. So anyway, we're going to have a look at this ECG properly just now. But the usual thing that we do, we first analyze axis, then we analyze rhythm. Then that's how you analyze rhythm over there. Then we analyze rate, then we analyze each zone. All right. So today we have a 54-year-old dehydrated woman with gastroenteritis and recurrent syncope. All right. And then this was what they saw during an episode of the syncope. And then after she came out of the syncope. All right. So this is what we saw. And this is what came out. So it's a rhythm disturbance. All right. If you want to be technical. So let's first start with the normal ECG that we find. And then we'll have a look at what happened during a syncopal episode. All right, let me just hide this. Okay. So the first thing we always work out is the axis. All right. So you guys know how to work out axis? Yeah, you can use that. Yeah, the thumbs method. All right, 1 and AVF. Right, both are facing upwards, so that's normal. Okay, then, oh, sorry. I don't want to give it away, sorry. Now what I was going to say was, there are a few ways to do it. I'll just do the way that we normally do on the group, right? Which is basically similar to what you're showing today. So what we say is that if you were to place everything in sort of like a grid form, right? So lead 1 normally sits here, all right? Lead AVF normally sits here at the bottom, right? In terms of how they look at the body, okay? This is the normal axis, left axis, right, extreme right and right, okay. So if you look at this one, lead 1 is positive, which means electricity is moving towards it, right? So if this is lead 1 looking at the heart, that means electricity is either moving in that direction or that direction for lead 1 to be able to see it, right? If it was moving away from lead 1, then it would be in one of these quadrants, okay. So we know we don't have a right and we know we don't have an extreme right, okay. And then we look at AVF, which is also positive. So we look at AVF, that means in order for it to be seeing electricity coming towards it, electricity is either in that quadrant or that quadrant, but we've already excluded that. So we know that it's in the normal one, right? But whatever method you use is fine, don't stress, okay? So we know that we have a normal axis, right? So let's look at the rhythm. So how do we look at rhythm? We've got a nice long rhythm strip over here, okay? So the first thing you normally have to analyze in rhythm is your P waves. Let's have a look at all P waves. We've got a P wave there, P wave there. Do they look normal? Yeah, they do look relatively normal. They're a bit, yeah, they're changing a little bit. Well, the spacing we'll get to just now, but in terms of how they look, we can see there's an occasional change in them, but generally overall they look all right. Okay. Then you look at the PR distance, all right? So that means from the peak of the P wave to the R wave. So you look at 1, 2, 3, 3.5. So between 2 and 4 is normal. But in this one here, I think you have to look at them a bit more closely because there's others where it's a bit shorter, but they still fall within the normal. Right? It's always between 2 and 4. Okay. Then you look at your QRS complexes. Are they narrow or are they wide? So what are we saying? Narrow complexes. Right. Does a QRS follow every P? Yes, wherever there's a P wave, there is a QRS complex, all right? And is everything regular? No, it's not regular. You can see there's these occasional, well, let's not call them ectopics, but let's just say premature, all right? Because you get sort of like P wave and then they come, all right? So it's not a regular rhythm, right? Which we can already get from there, but we'll get back to it now. The rate that we're looking at, we have to look at the fastest rate. So you take the 2 closest PQRS or QRS complexes, right? So it's about 1, 2, 3, 3.5, in about 90 beats per minute. So that's relatively normal, okay? Now, even before we start, or let's look at the zones quickly, then we'll go back to the lady and we'll have a look at what's the story. So which zones do you guys know? In other words, which part of the heart do which leads look at? So for example, if we were to say leads 2, 3, and AVF, which part of the heart do they look at?
All right.
Inferior. All right. So if you look at the heart, leads 2, 3, and AVF, look at the inferior part of the heart. Okay. So when you say that you have zones, what you mean is you expect those parts of those leads to give you a similar picture. Hello, somebody talking there on Zoom. Sorry. Or is it just that somebody's mic is not muted? I don't know. Sorry. We've just got iPhone. Sorry, I think we're just getting some feedback from you. I'm just going to mute. It may be easier for you guys to talk on, to rather put things on the chat. It's easier for us to follow. All right. Okay. So one of the zones, like I say, is 2, 3, and AVF. So to give you an example of what that means, so like 3 of you are sitting there, and if I ask you to describe my face, you'll each give similar but not exact descriptions. Okay. As compared to him who's sitting right on that side, he's going to give a completely, somebody who's sitting here is going to give me a. So that's what we say when we analyze each zone. All right. So this is the inferior zone. It's 2, 3, and AVF. What do we notice? Is there anything to pick up? Anything that seems strange? Anything that seems abnormal to you? There's one thing you should be picking up because you've got a P, Q, R, S. And what's missing? Yeah, you're not getting any T waves over there. The T waves are flattened. All right. So that's abnormal. You shouldn't have them. All right. So that's one thing that you could pick up. You could argue that there's maybe a little ST depression, but it could also just be a slight slant or things that we're not picking up. But anyway, that we'll get back to in a second. All right. The next zone we'll look at is the septum. All right. So V1 and V2 are what we call the septal leads. All right. So they look at the septum. So what do we see in V1 and V2? Anything that's abnormal or anything that's strange? Not much. Again, maybe just the T waves. Yeah. V1, V2. Well, they're supposed to be here, you know. So this is an RS, right? So when you have your first upward deflection is called an R, then your downward deflection is called an S, right? That follows. So RS is quite normal. You're supposed to have that in V1 and V2, right? So the one thing that we notice in V1 is that our T waves are also flattened. And when we do have a T wave, you see how far away it is from there. All right. So that's a QT prolongation. All right. So do you guys have any idea why do we get QT prolongations? So the first thing, whenever you see a QT prolongation, think hypo. All right. Hypo everything. Hypokalemia, hyponatremia, hypocalcemia, hypo everything. Whatever can be hypo, that's a possibility. All right. So that's the first thing that comes to your mind. So anything that could be hypo. Then the next thing that comes to your mind is drugs. So there's lots of drugs, right, that causes calcium channel blockers, tricyclic antidepressants. There's a whole bunch of them that actually cause this QT to become prolonged, okay, because they affect the channels in the, in the heart, okay. So that's the two things that you start thinking. So if this is like a patient with an overdose, query overdose, like for example, let's say, okay, there's a possibility this patient may have overdosed on something that's cardiotoxic, all right. If it's a patient, for example, like what we've got, patient with gastroenteritis, what would we suspect? Hypokalemia, very good. So we start thinking of something like hypokalemia, maybe hypocalcemia, hyponatremia, because she's been losing quite a bit. Okay, so we can already see we're going down that line. Okay, all right. Then we come to the anterior leads. So the anterior leads are V3 and V4. So they look at the anterior aspect of the heart. So what do we notice over there? Again, just this long QT interval, all right? Very long QT interval that's going on. And here in V4, we see this odd beat that's taking place, all right? So what do you see before? Is there anything strange that happens before that? Or what's supposed to come before a beat? A ventricle, yeah, there's no P wave here, all right? So that means the ventricle is just on its own, all right? So it's a premature ventricular complex, or a PVC, all right? Whereas if it was an atrial thing, then it'd be a premature atrial complex, all right? Okay, so you get the idea of why that's happening. Okay, so we've got this premature, but it's only coming up once, all right? We've only seen it once. Then if we look at the lateral side of the heart, we've got V5, V6, and 1 and AVL. V5 and V6 sit here, all right? And then 1 and AVL basically look at the heart from there. So they're sort of forming a crisscross. So they're looking at the heart from 4 different aspects, but they're all looking at the lateral border, right? So V5 and V6 are your lateral leads, and leads 1 and AVL are called your high lateral leads, okay? But we expect them to give a similar sort of picture. But what do we see over there? Again, just this long QT. Eh? In this one here, we see, okay, the QRS complexes are a bit small, right? But that could also be because of distance, where they're placed, you know, things like that, because you don't really see it anywhere else. So it might just be the placement of the lead or something like that. What we see here specifically in AVL, that's quite different to the others. Which way are all of these pointing? Okay? All pointing upwards. All right. Which way is this one pointing? Is that supposed to happen? No. So it's an anomaly. All right. So why is that happening? Why could that be happening? I wonder. Why is AVL seeing only Q waves? All right. So it's something you've got to think about. All right. I don't have an answer in this particular case. I'm just saying. All right. So it's an anomaly that you've got to think about. So it may be also having to do with lead placement, maybe having to do with rotation of the heart. There's quite a few things that could happen that could explain it. And then the last one that we look at is AVR. So AVR is looking at the right side of the heart. All right, it's often called the forgotten lead because it only looks at the heart from one particular side. Okay, so last week we were talking about AVR and overdoses on Friday. So because we had already seen a prolonged QT, we would look more closely at AVR to see if there's something to suggest that. But in this case, there isn't. All right. But the one thing we pick up is this prolonged QT. So in other words, there's a long time between the heart contracting and the heart getting ready again, all right, to contract. And we see that when the heart is getting ready to contract, it's not doing a very good job because everything's kind of flattened and it's not really picking up, it's not producing a lot of electricity. So in other words, the heart is struggling to get back to where it was and then contract again, all right, if you have to think about it in simple terms. And what we said was one of the reasons for that to happen is all the hypos, all right, because your heart is dependent on every single electrolyte that's out there. You name it, it's dependent on it, okay. So we look back at our patient. So a 54-year-old dehydrated woman with gastroenteritis. Let's just stop it there, gastroenteritis and recurrent syncope. So all four of you, sleeping in your car, you are now the ComServe, you are working in Flighties Fontaine, where you're the senior doctor for the hospital, basically, all right? There's one intern, maybe one clinical associate on call. It's 3 o'clock in the morning, they phone you. They say, listen, we've got a 54-year-old dehydrated woman. She's having gastroenteritis and she's just having these periods of syncope. And we've got something very strange on the ECG. So you wake up from your car, you have your smoke, you're walking back. What's the first few things that you think of? In other words, what's your differentials? That's what I'm asking. So why would somebody with severe gastroenteritis be having syncope? That's what you got to think. So, yeah, right? So electrolyte imbalances will already be in your head, all right? Because she's she's dehydrated, so she's obviously lost a lot of, fluids through there. And which are the most common ones? Potassium, sodium, calcium, chloride. Any others that you think of? Yeah, you think of your CMPs as well, all right? So that's where you'd be going as well, all right? Anything else that could be causing it, maybe? She's dehydrated, so you expect her to have low BPs. She could be in hypovolemic shock, very good. So that could also be the reason why she's going in and out of consciousness. You didn't ask the BP, you don't know the BP. It could be 60/30. Every time she tries to sit up, she goes down, all right? So that's one of the other things. Anything else that could be causing it that you could think of? Yeah. Yeah, it could possibly be something from there. It is possible, but we wouldn't think of it initially. So you'd be thinking of those two things, all right? So then you come in, you don't worry about this, all right? Because it looks strange, so you put it on the side. So you have a look at this first, right? And then you have a look at that, and then it tells you that, okay, maybe something is hypo over here. So everything comes back as hypo. And you say, okay, everything's coming back as hypo. And next thing, she has a syncope again, and then you see this. So that's your rhythm stroke. What are you going to do? Panic and look for Dr. Mohammed's number and see. Okay. Torsades. So what is torsades? All right, but anyway, let's analyze it. All right, so what's happening here? What have we got? What does this look like? First of all, when you look at it, it's a tachycardia. All right, it is a tachycardia. Okay, so the heart suddenly goes into this extreme tachycardia. of about nearly 300 beats per minute. Okay, so it's extremely fast. All of a sudden, the heart just starts pumping away like that. And it's a ventricular tachycardia. Why do we say it's ventricular? Because it's quite wide. All right, right. It looks wide. But what's odd about it is that it's kind of going in this odd pattern, you know, that's going up and down. Yeah, it's going like that. All right. So we know that we have ventricular tachycardia. Okay. The patient is obviously unstable during that time because she's going to have low BPs. She's going in and out of consciousness. So that's the very definition of an unstable patient. So how would you treat a ventricular tachycardia? That's my first question. How do you treat a ventricular tachycardia when it's presented to you? Besides giving the patient to the COMSA, what do you think? What would come to your mind immediately? Cardioversion, very good. What type of cardioversion? There's a specific type. No, it's not pulseless. She's just a ventricular tachycardia. Because if it's pulseless, then you've got to start CPR and shocking, all right? But if it's a pulsatile, which we say this is, there's cardioversion that is asynchronous and synchronized cardioversion, all right? So what is synchronized cardioversion? Synchronized cardioversion is where you try and match the cardioversion or the electrical impulse to the peak of the R wave, all right? In other words, you're trying to stop the heart at its very maximal contraction. So at the moment that it's at its worst, you know, it's tight, boom, you just stop it dead in the hope that when it restarts, it will restart normal. That's basically what synchronized cardioversion is. Okay, so all right, you put on synchronized cardioversion, it doesn't work. All right, it doesn't work on this particular patient. Okay, so is there anything else that you can do? Yeah. Non-shockable rhythm, that's for sure. But you must remember the non-shockable and shockable rhythm comes around when you have a pulseless patient. This is a pulsatile patient. She has a pulse. So that's why I say we're treating this as a tachycardia. Right? What type of a tachycardia? A ventricular tachycardia. Right? So let's stop for a moment and talk about ventricular tachycardias or tachycardias in general. So when you have a pulsatile tachycardia, you have two types. You have stable and unstable tachycardia. So what is a stable tachycardia is a patient who has normal BPs, normal level of consciousness, no evidence of heart failure, no anginal symptoms, and what was the last one? There was something else, right? But normal BPs are your first and most important thing, all right? So if your patient has a stable tachycardia, the first thing you would do is chemical cardioversion. And what is chemical cardioversion? Adenosine, amiodarone, procainamide, there's a whole lot of drugs. We talk about tachycardia separately, all right? But just to give you a quick reminder. But what if your patient is unstable? So your patient unstable, low BPs, decreased level of consciousness, anginal ongoing pain, heart failure, things like that, which our patient is having. You know, she's having syncope. She's having a decreased level of consciousness, most likely low BPs. So you can't waste time with chemical cardioversion. You have to immediately go to electrical cardioversion. Then electrical cardioversion is different. You have what you call supraventricular tachycardias or narrow complex tachycardias and wide complex tachycardias. So which one is this? Wide complex tachycardia. All right. So you're going to do a synchronized cardioversion at wide complex tachycardia. How many joules do you think you're going to use? A lot or a little? Even if you can't remember exactly. A lot, right? Because you have to attack the ventricle, right? As compared to a narrow complex tachycardia where you could use a little bit, right? So if you ever get lost or you ever get confused, the machine normally helps you out because it starts at a sort of an in-between. It starts at 100, right? So 100, if you give it to a supraventricular, you're not going to kill the patient. You give it to a ventricular, you're also not going to kill the patient, right? But to be very technical, when you have a narrow complex tachycardia, you start at about 50 joules, 70 joules, 100 joules. And when you have a wide complex tachycardia, you start at about 100, 150, and things like that. Right? All right, morning. Come sit. Now, even when you look at that, oh, yeah, you can take this, no problem. You can have a look here. We're looking on the big screen. All right. So even when you look at the algorithm for tachycardias, ventricular tachycardias, it divides them into two types, monomorphic and polymorphic. All right. So monomorphic, in other words, would mean that the ventricular tachycardia, everything looks exactly the same. Is that what we have here? So this is actually, we have a polymorphic ventricular tachycardia. So now you're really searching for Dr. Mohammed's number at 2 in the morning. Okay. So you've tried everything. It's not really working. All right. But you actually gave us the answer, right? Which we're going to go to just now, right? So once you have a polymorphic ventricular tachycardia, you can try cardioverting and things like that, but chances are it's not going to work. Right? Let's have a look at what is the answer to this one, and then we'll talk about actually what happens. Okay. So we have a polymorphic ventricular tachycardia, suspected Torsades de Pointes. So they put the rate at 220. All right. So the rhythm is a wide QRS complex tachycardia with continuously varying QRS, which we have already seen. All right. Variation in RR intervals, variation of electrical acids, da 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 da. So the QRS complex appears to rotate around a fixed point, growing large, then smaller, then larger and smaller, and so on, which we're going to look at now, right? This pattern is suggestive of Torsades de Pointes, all right? Torsades de Pointes is a type of polymorphic ventricular tachycardia characterized by its unusual morphology. It is also defined when the baseline ECG demonstrates a prolonged QT interval. So that's a lot of information to take in. All right. Basically, we're going to look at what a Torsades is supposed to look like. Okay. Because you must never forget this. This is the type of thing that you may see once every 2 years, once every 3 years. But it's so easy to sort out. And when you see it, you'll be the hero when you sort it out. Okay. All right. Now, the second part is just telling us about the other thing that's happening. Right. So sinus rhythm, rate 64 kV/hour. It does have some PACs. Okay. No problem. And PVCs that we're seeing. Anteroseptal ischemia. Prolonged QT interval. So the anteroseptal ischemia, they are basing on this ST depression. Okay, so that was one thing we should have looked at. All right, prolonged QT interval. But the major abnormality here is a prolongation of the QT interval. All right. So the QT interval, okay, so we had already covered this in a previous one, but essentially when it's greater than 450 in men and greater than 460 in women and children. All right. So, okay, in this case, it says the patient is at risk, but the patient is not only at risk for Torsades de Pointes. This is also due to hypokalemia, hypomagnesemia, hypocalcemia, acute MIs, elevated intracranial pressure, drugs with sodium channel blocking effects, hypothermia, congenital prolonged QT syndrome. So you can see when you have a long QT interval, there's a whole lot of things that happen. Okay, but the one thing that we have here is something called Torsades de Pointes. All right. So Torsades de Pointes is a thing that you will see once in a while. And it's most normally due to low magnesium, okay, which we would expect in somebody who's dehydrated from AGE, okay. So as you can see, basically what they're trying to point out to you here is how it goes up and down, and then gets smaller, bigger, smaller, bigger, smaller, bigger. So Torsades de Pointes is actually based on a ballet term. This is where they got the term from. And do you see what it looks like? Okay, so that's basically what it is. Over and over again. That's what the heart keeps on doing because of lack of magnesium. So how do you treat it? How do you think? Give the patient magnesium. That's it. That's all that you have to do. Give the patient magnesium. So you've been burning that heart. You've been giving them this and giving them that. When you see this pattern, the only thing that you do is you give the patient magnesium. So the question is how much of magnesium? It depends on the duration. So that's somewhere we probably have to ask a senior person. Right. But as a general rule with magnesium, just as long as you don't go above 4 grams, you're going to be okay. And just don't give it as a bolus. Okay. So, for example, if you have a patient who's got, what you call it, an eclampsia, how do you treat them? You guys should know that. Magnesium sulfate. How do you give it? You can either give it IM, IV, all right. But in this case, you prefer to give it IV. But let's say you forgot and you gave it IM, 5.5, you'd be okay. When I say 4 grams, I mean IV dosage, all right. So IV, we would give them either 2 grams or 4 grams, and we try and give it over an hour. So what will happen is as you slowly give it, the patient will start to settle down, and they will actually go back to normal. Okay, so it's not the most common rhythm that you will see, all right? But when you do see it, you must know what to do. Because the reason why, like I say, now we've been doing this for, now we're on our 6th month, right? So we've covered tachycardias, we've covered a lot of things. You can go back and have a look at the whole lectures, you'll see. So this is an odd tachycardia that will come up once every 2 years, once every 3 years. Sometimes you may go your whole lifetime and never see this, all right? You may only see it if you work in emergency departments. We've only had one in the last 6 years that I remember, right, that we had. It was a similar problem. Came 2 in the morning, they phoned, they had to come out, and we gave the patient magnesium and everything settled down, all right? Does it mean the patient will be okay once you give magnesium and everything is settled down? No. because the patient has still got AGE, he's still going to be losing magnesium. So there's always a chance that they could go back into it. All right. So once that happens, and once you start giving the magnesium, patient should be all right, but the patient needs to be monitored in an ICU setting. So whenever you see an ECG that looks like this, don't ever forget it. All right. You give magnesium. Okay. So that's just a joke to finish off. All right. But now this was a bit of a so this was a bit of an odd one, right? That I just wanted to throw in the middle of this whole series that we've been having. Okay, but when you start analyzing any ECG, remember, go step by step. All right, and when you go step by step in that ECG, you get at least to the QT prolongation. When you get to the QT prolongation, then you start thinking about. And if you can't remember all of the differentials, you just pull out your phone. If you don't have data, get 50 cents of data. It's more than enough to look up the list of QT prolongations. All right. And then you say, okay, I've got this, and this. And then you say, okay, I'm going. And at the top of it, you even see hypomagnesemia comes up very often in QT prolongation because it's one of the most common causes. Okay. Then you look, okay, I've given potassium, I've given sodium, I've given this, I've given that. The patient's not taken any of these things. It could be an MI, but I'm still waiting. Okay, let me look up hypomagnesemia. I look up hypomagnesemia and I see this thing doing that. And I say, that looks exactly like what I've gotten. Remember this ballerina dancing? Okay, shit, it's magnesium. Right, let me give it. And you save the patient, and that's about it. But then the patient needs to be transferred to a high cardiac care unit. Okay, because the patient is at risk of other things later on, which you're not going to get into too much right now. Okay, but remember, at the end of the day, be step by step, go in a systematic fashion, and you'll never go wrong. Right? So especially if you haven't been part of ours before, I know it's a bit intimidating to start off with something like that, but like when you go in the group, just go back. I'll send you the link to the old lectures. Have a look and you'll see we built up to this. All right. So don't worry. Okay. So if you guys don't have any questions, and we've got we've got all the people on Zoom as well. If you have questions, by all means, you can always ask me later. We can always go through. But if you're worried about tachycardias, go back and have a look. We've got a whole lecture series on tachycardias that we did. Okay. And then we can take it from there. Okay. So we're going to stop there, and then we all get back to work.